Yeah, just whatever you found.
Yep,
just whatever you found. So it's interesting when you look at survey data versus clinical data.
Right.
And you have to keep in mind about where this data was collected, right? How it was collected, what was the population that it came from. And then also there's different rates with which different racial groups or gender or income groups respond to different types of things. So whites are much more likely to participate in clinical research and have higher levels of medical care. And then depending upon some of these national surveillance systems, they may have oversampled minorities. So you may see different things than what you'd expect in a clinical study.
Oversampling is like the term raking, is that correct? That's oversampling?
Where you want to focus on specific minority groups. So if you think about what the population breakdown is in the United States, if you oversample, say, African Americans, or if you're oversampling women, you might get a higher proportion than you would see in the population. And then also if the advertisements or the recruitment, as it's called, for these particular surveys is done through, like if you did it through the Camellia group here, which is really high income, versus if you recruited through free clinics, you're going to get a different population. So just explain what you saw, and it may be counter to what you were expecting to see, but that's really the beauty of data, is that you shouldn't ever actually know what's going to come out of it. Now, you always want to be really careful, and this has in fact happened to me in the past, where I've been working with the same group of people for a long time with the same data from clinics, and we're well aware that African American males should have the highest blood pressure, and when I get the data, I see that it's the reverse. And then I go and I check the data dictionary, and they had a new fellow that coded all the data, and they reversed the coding. Right? So, yeah, I know Candace's face was like, what? Yes, this is why we spend so much time at the start of the course going through your data and making sure that your data matches the code book and that you've got it correctly coded. And that's happened to me on more than one occasion where somebody has either sent me the incorrect data dictionary or the coding has gotten reversed. And so when I'm working with people and they send me data, the very first thing I do is recreate their summary statistics. And I will send that back to them and say, is this the breakdown you expected to see in gender, in race, in the baseline blood pressure values? And I allow them to look at it so they can go, oh my God, no, we sent you the wrong data, which has happened as well. Or people only send you one spreadsheet. People keep data in really weird ways, and they do it very poorly. And it's not until they take a statistics class that they realize that there are better ways to keep data. A lot of times what people will do is they'll keep two separate Excel spreadsheets, like one for whites and one for African Americans, or one for people that are taking this medication, and they'll keep a totally other spreadsheet for a different medication. Don't do that. Keep everybody in the same spreadsheet and create a column for race or create a column for the medication that they're taking. And that way you don't have to try to keep track of data in two separate locations.
I'll hold the rest of mine for somebody else to come pop in.
Okay. Other questions from people? Doesn't have to be just a conversation between me and Ron.
I just it wouldn't be. Feel like I'm dominating the group. I don't mean to be.
Well, the last module, learning check, is optional, and most of what people have done, hopefully your data briefs are rounding out to be completed. And so unless you have any specific questions, anybody else, go ahead, Ron.
Well, you were kind of big on the HP 2020 linkage, and we found that we did not have a good continuous variable. So we did something else. Is that going to be a problem in terms of grading?
That's fine, as long as, I wanted people to explore it, but sometimes it doesn't happen that way. There's not a good...
We did explore it for sure, man.
Yep.
We just didn't find
That's fine.
fit. And I think we have a pretty good study, but okay.
That's fine. If you are on a team that I submitted for review, I would have noted that there was an issue.
Okay. One other question I have regarding the data brief. somewhere along the line, I read 4 or 5 pages was what you wanted. But unfortunately, our graphs get compressed quite a bit, and I would respectfully request to have more pages. I don't want to be a doc for it. We got it down to 5 pages.
5 is fine. 5 is fine.
Okay.
One of the things that we try to focus on here is it's brevity. If you look at the examples from the CDC data briefs, really if you have 4 questions, 5 pages should be sufficient. Your first page would have the introduction, it would have your summary of your cohort, and then really you should be able to get every graph and every paragraph on a single page, right? So if you think about the graph taking up a half page and then a paragraph to describe what you found, and if you have 4 questions plus your intro, that's 5 pages. We don't want you spending a full page of writing to explain something that really only takes a couple of sentences.
I understand that. Would we be a doc if we had 6 pages?
No.
Okay. That's all I didn't know.
I just don't want 12 pages.
Well,
Right? Because 12 times 12 is 144 pages that I have to read.
Where do you want us to submit our responsibilities? That's something you mentioned one time, and I'm not sure where. I noticed on your paper on the marijuana, you had everybody was listed, but I don't see any others like that.
Nope, you don't have to worry about that as long as you've got your names for do you guys really listing the responsibilities was on the team minutes throughout so that you were aware that you had shifting responsibilities? Your final data brief is a team effort.
So you don't want to see what we've accomplished individually?
No.
That's great. I mean, I
just
like
your
that.
names.
Okay.
Anybody else? Short today.
I'm looking.
A question about like I emailed you, Dr. C, for my table, right? Like the data brief.
Mm-hmm.
I did the same mistake in my learning check 9 table where you had to do rows percentage rather than total or column.
Mm-hmm.
And I got that I have recorded 0, like, so mine, ours is MMR shots, right? 0 versus 1 plus shots in the children aged 3 to 19 months. So I got the comment where I need to results because I think that's what I made a mistake. So rows percentage, I'll report it, but do I have to re-report the whole analysis? Because of that, it'll change, right? Everything?
Nope, it doesn't change. So let's take a quick look here. I'm just going to do race by any alcohol or drug use. This is the homeless women. So if I put any alcohol or drug and I look at race categories and I run that, it's just a fit Y by X.
Mm-hmm.
You get the same results regardless of whether you report row or column percentages.
Okay.
So if I hide my total percents and I hide my column percents, you can see that none of this changed.
Yeah.
Right? So you don't have to redo the entire analysis. What you may have to redo is your figures. You may have to change your figures to indicate the row proportions.
Mm-hmm.
But this part won't change.
Yeah. So when I reported 0 shots, like, do I have to report 0 and versus 1, or because I just reported 0 shots, number of 0 shots?
Right. So that's fine as long as it's clear that the alternative to 0 shots is at least 1 shot.
Okay. All right. And I have tried to email you the whole thing, what I had. I wasn't sure how to email, do it other way around. So I've done it. And if you can please have a look. And I can send you my comments on my quiz, so it'll be easier that.
So I can see, like, if you send me, I just can't access your Google Docs because to do that I'd have to use my personal email, and I won't do that on course related issues.
No, that's fine. I send you the Word. I put it in the Word document and then I attach the file.
Okay, I'll take a look at it after this is over.
Yeah. Okay. Thank you so much. And I'm going to copy paste the comment you have made, so it'll be like maybe it might.
Okay. Sure.
Thank you so much. This won't change. Okay. Perfect. Sounds good. Thank you.
Other questions?
Dr. Cofield, I have
Yes.
questions.
Sure,
So-
Eleanor, go ahead.
Okay, so I sent you an email about the last learning check about the number 10.
Okay.
I couldn't go to the TA's office hour, but apparently the reason why everybody's missing that, or the predominantly the reason is because we're supposed to code desirable and not desirable dichotomously. You cannot do like borderline desirables and not desirable. You can,
Correct.
and I don't understand why that would change. Like how many, like the people who are the numbers of patients who are supposed to be in your data should be
So
the same for desirable.
it
whether you
won't-
code it.
It won't change the number that are desirable. What it will change is the people that are not desirable, right? So before you had 3 categories. You had desirable, borderline high, and
Oh.
high, right? You had 3 categories before. So
Yes.
if it's desirable versus 2 other categories, that's what you did. Otherwise, it's desirable versus not desirable. So you need to combine, you need to combine anybody that's not desirable into one category. And so let's do an example here, right? So right now I have 3 races, right? If I go in here and I do race in 2 categories,
Mm-hmm.
and I'm going to do a little formula. I could do a recode as well, but I'm just going to do a formula because I know how to do that real fast. Right? And so if I do this non-white, right? So this would be similar to doing not desirable.
Mm-hmm.
And I press OK. And now I have this new race with 2 categories. And I go back into my fit Y by X. And I do my
Yeah,
race 2 categories. And I do my any drug alcohol. And I press OK. And then I go back here and I can compare it to my original one.
Mm-hmm.
You can see that my test results are different.
Yes.
Right? Because in this case, I had 3 categories, right? I had African American, Hispanic, and white. And in this case, I only have white and non-white. So the statistical results are different. The percentage of people that, in your example, that were desirable would stay the same.
Right.
But the statistical comparison is different because you're comparing desirable to non-desirable versus desirable to borderline and high.
Okay.
So that's why it's important to do the dichotomous recode.
I totally missed the question because it says to compare those with desirable and borderline high or high. Oh, so
Yep. So it's a combination. When you create an indicator variable for desirable versus not desirable, then you're combining the other 2 categories.
Okay. I was like, I suck. Anyways, okay. So I have questions for the learning check 11.
Okay.
So when you ask analysis results, I thought the result is whether we have evidence or we don't have evidence. Isn't that the analysis result?
That's your decision. Yeah, that's your decision. So this is the results of the analysis.
Okay.
Right? So what's the result? And then your decision is based upon that result.
So for the multiple linear regression, we should put, what are the things that we should provide? What are the figures? The likelihood ratio?
Right. So if you go back to the notes, right, and look at so it depends on what the question is. Let's go take a look at this learning check. Thinking about it. Okay, so this
the number 11.
Number. There we go.
Okay.
So let's take a look at here. My computer has decided today is the day to be slow. Okay, so when we're talking about what are the results, so we're looking down here, interpret each of the significant predictors, use multiple regression to conduct association between years homeless, use a general guidelines to report the results of this model. Is this what you're talking about?
As well as the question, number 6 and 7 and 8. Yes. Okay.
So interpret each of the significant predictors of poor health. So when I ask you to interpret, that's what does it mean?
Okay.
Right? What does it mean? Right? And then using the general guidelines to report the results of this model, go back to the notes and look at how we talk about reporting the results. In general, in the past, what we've done is we've given a summary of, we've stated what our question is, we've given a summary of the results, and then we've interpreted what they mean. And that includes including a p-value for your test. So if we had a t-test, it would be, I want to compare the mean blood pressure between males and females. The mean blood pressure of males was this, the mean blood pressure of females was that. The t-test gave me this p-value, and therefore I've declared that there is a significant difference between males and females. Right, so if we go back to the notes from the beginning of the semester, we have 4 steps to answering the question. Right, and that has applied to every single analysis method that we've used. What's your question? What did you see? What does the statistics tell you? And what's your interpretation?
I'm just confused of what are the figures we should provide for the multiple linear regression.
Did I ask you for a figure? I think I asked you for...
No, I thought you have to report the p-value, and what else do you have to report? So
it's going back to the general guidelines to reporting anything, right? What's your question? What do the statistics tell you? What's your interpretation? So when you have linear regression, when you're looking at a linear regression, so let me close this here, right? And if I'm looking at predicting the years homeless, right? So how many years are homeless? And let me just put in any drug or alcohol and the race of someone, right? So my first question is this model useful? The answer to that question is yes, this model is useful. Then I want to take a look at the individual parameters. And in this particular case, in this particular model, race is not statistically associated with the number of years that someone has spent homeless. So I don't actually need to report anything beyond that. Race is not related. And here's my p-value. And if I look at any drug or alcohol use, right, any drug or alcohol use, that's this. It is it's significantly related. And then this is basically reporting what's the mean number of years homeless by these two groups. This defaults itself to a 2-group t-test, right? Because it's comparing whether or not so those without a history of drug or alcohol use have been homeless for an average of 1.4 years. And those with drug or alcohol use have been homeless for an average of 3.6 years. So the inference you could draw from this is that a history of drug or alcohol use is associated with a longer number of years spent homeless at the time of this survey compared to those without prior drug. And then here's your p-value. So you don't need to report. So basically all that modeling does is it takes our unadjusted tests, right, and combines them into a model where we're considering multiple factors. But both of these predictors here only have 2 levels, and we have a continuous outcome. So the interpretation of them is it's identical to interpreting a 2-group t-test. We've got a continuous outcome, and we've got 2 groups here. We've now just adjusted for race.
Okay, now I understand. Thank you.
Sure. Other questions?
I think 7 was confusing, and I think I uploaded my results because I was like, it's asking to choose a file. So
right, choose a file, but you can just upload what you would write. But you also, your results are fine. But as soon as you use the general guidelines to report results, that's asking you for your interpretation. So this way is you can upload a file, right? And then this way it says, I want you to just type the paragraph. It's basically asking you 2 of the same things, but it's asking you to do it in a different way.
Okay, I have a dumb question. So,
If you
question
don't know
number
the answer, it's not a dumb question.
5. How do you figure out which predictors are independently associated with the other, the outcome, or which are dependently associated with the outcome?
Okay, so once you are in a situation of fit model, right? So I have 2. This is called an adjusted analysis because I'm adjusting for other factors. They're not independently related in that manner because we're adjusting for something else. I'm not sure that your terminology is quite correct.
It's question number 5.
Okay, so let's go back up to question 5. So this is asking for bivariate linear regression. So that means it's just 2 variables, right? That's a fit y by x.
Right.
Bivariate linear regression means only 2 variables. It means a single x and a single y. Okay, so you're going to have to run individual fit y by x's.
Okay. Oh.
So
and
there's
is there
4 of them.
significant? Okay.
Yep. There's 4 models, but it's fit y by x to run 4 analyses.
Oh, okay.
And so that's where you have a single x and a single y. And so I want to know if that x is related to that y. The next step will be to put them all in a model and see if they're all related to simultaneously. It's a stepped process. Other questions about that? Bivariate's 2 variables, multivariate is multiple, is more than 2.
What is a Wilcoxon test and how is it different from the ones that we have learned?
Wilcoxon actually looks at the median instead of the mean. So if we go here, we don't get into in this class. We just don't have enough time in this class. But if we go into a fit y by x, and I want to do a 2-group t-test, right? So years homeless, and we'll look at race in 2 categories. What we've been looking at is the t-test. You can either do the pooled t or the regular t, right? This assumes normality. Remember, this assumes that we have a large enough sample size, or this is based on comparison of means. Means are bell-shaped distributions, symmetric distributions. If I have really skewed data, or I have really small sample size, like so less than 30 in my n, and what I wanted to do was a Wilcoxon, you see there?
Oh.
Yep.
It's non-parametric.
Yep, it's non-parametric. So a mean is a parameter of a distribution. So our standard, this is just outside of this course, but our standard normal, remember, has a mean and a standard deviation. Those are called parameters of the distribution. So a t-test is a parametric analysis. The Wilcoxon compares the median. And the median is not a parameter like a mean is. The median is a single value. The mean we're estimating. The median just is. It's the middle of your distribution of your data. So we're not doing any math to get your median. It's just the center value. Right?
Okay.
So you can consider a parameter is something that we're estimating. It's going to involve some kind of math to get it, like a mean where you add everybody up and divide by the number. The median's just the middle. And so the Wilcoxon is going to compare the center of your distribution using a median. And that's if you don't want to assume normality, if you don't want to assume that it comes from this symmetric distribution. So if you have really skewed data, we often do the non-parametric comparison.
Okay, that makes sense.
The interpretation of it's very similar, right? We get a p-value, and we would then say, in this case, that there's no difference in the median number of years homeless between non-whites and whites. as opposed to this result talks about the mean years of homelessness.
Oh.
Ah, it's fancy. Other
Then I'll
questions?
answer this.
Huh?
I have a question about the final quiz.
Okay. Any other questions before we go on to that? Any other questions about this learning check
Sorry.
from anyone? Any linear model questions? Okay, go ahead, Ron, on the final quiz.
Yeah, and I know you don't want to give us the answer, and I understand that, but I'm having a hard time understanding the population of reference in Q3
Okay.
because they all sort of apply, and I understand the idea of reference.
Okay.
Reference.
Let's take a look. Let me get back up here to quizzes. Final exam. It's not really an exam. Okay, so we have this paper, right? Which you guys have read. And this, based upon the abstract, what's the population of inference for this study? So, let's talk about our options here, right? So, what is the abstract? What is the sample of our data? It comes from this NARCOMS, right? Comes from NARCOMS.
Correct.
So if we think about what you guys have been working with, your data that you've been working with for your data brief, right? There's always been a paragraph that tells you where the sample came from and then what the population of interest is.
Right.
Mm-hmm.
So can you then transfer your ability to understand that, right? That we're looking at, say, homeless people. Like we want to make inference about homeless people in the United States, but we've collected data in Los Angeles, right? In this particular instance, the data has come from the NARCOMS survey. Can you determine who that applies to, right? So what's the name? It's the North American, right? North American Consortium or Research Consortium on Multiple Sclerosis, right? So do we think that the results of this study only apply to people in NARCOMS? Do we think the results of this study apply to all people with MS, like in the whole world? Or do you think it only applies to people with MS in North America?
I think, and can we?
I mean, I'm not going to give you the answer, but you can. Yeah.
Okay, so because some of the question asked on the survey, it's like where you live is legal. Those are very specific questions for regions. So I feel like this results only apply to the people in North America because, like, that's where they collect that's the whole population, and they can't make inference on everybody with MS because they have very specific.
Well, I thought that was true, but then I saw the world. I said, why not?
because a lot of places are not legal with marijuana, so they.
Well, it's not even about. So let's take a look at it. It's not even about a lot of places not being legal. It's about the people who answered this, like who was available to answer these questions, right? So if we take a look at participants, to do if my computer will. Good Lord. I am not a fan of this new update on Acrobat. It wants to index everything before it lets you start looking at it. Participants in the registry, right? So North America should be a clue, right? Were surveyed on legality and history. So we wanted to know, and then if you look at this, right, 64% had tried marijuana prior to their MS diagnosis. So we've got results. We've got people having the disease, a relapsing onset. We've got the word diagnosis. We have the words North America. So see if you can figure out from that who the general population that we could apply these results to. Do we think that these results are applicable to people who are living in China?
Nope.
Why don't you think they're applicable to that?
Because they're not available to answer the questions on the survey.
That's a ding, 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 ding. right? So see if you can work your way back to that.
I appreciate it.
Okay.
Okay, this may be a cheat question, but can you explain the y-axis on figure 1, please?
I don't know. Let's see if I can. I created the figure. One would hope that I could. So this one, what's the y-axis?
Yeah.
It's the odds ratio. It's the odds ratio. So if you look at the logistic regression notes.
But what is it says like score versus normal. What does the versus normal mean?
So that's our reference category.
Oh, okay, I got it. Okay, so the higher that it is, that the more like at risk or
right. So if you go back to the interpretation of odds ratios, if an odds ratio is greater than 1, that means that this group has a higher risk compared to that group. Right? So the odds of current use of marijuana are more likely, so people with higher disability are more likely to be currently using marijuana than those with lower. That's what an odds...
I'm just a little confused because it seems like the trend is increasing 1 versus 0, 2 versus 0 until it reaches 6 versus 0, then it's like not with the pattern anymore. So can we even account? Can we say, oh, in general, it's increasing, but until it reaches number 6? I don't know.
I don't know. Can you? Right. So there's a couple of different ways to look at this. Yes, in general, those with higher disability are more likely to currently use marijuana than those with lower disability levels. If you read the paper, we'll go into that. So there are very few people with an 8 that have actually answered the survey. So that could be a power issue. It could be a sample size problem. 8s are wheelchair bedridden. They're bedridden. They're probably not that likely to currently be using marijuana because somebody's going to have to go buy it for them.
True.
Right? Or they're on other medications where it's not required. This is going into a deeper discussion on than what's required for this quiz. And then 6s, again, it might be a sample size related issue, but it is the direction of the difference is very similar. It's just not statistically significant. This was a fun study.
Yeah.
It was my study. Huh?
Did you do any sampling?
Nope. Yeah, it's interesting. So we published on this, and we presented on this at a couple of different meetings and a lot of interviews. And back a number of years ago, a lot of physicians wouldn't ask patients about this.
Right.
They didn't think it was useful. And I said, we sort of said, but patients are using it. And so you have to ask. And a lot of physicians, you hear about that like, oh, I don't condone people getting high. Yeah, I don't either. That's not why they're using. And if we could get control over it, then you can regulate THC versus CBD. And it's the high CBD, that's the cannabidiols. That's the non-hallucinogenic or non-intoxicating part of marijuana. So the CBD, the cannabidiols, that's, if you've been looking at or keeping up with things like for kids for epilepsy called Pop for Peds, it's the CBD that's really beneficial. And so it would behoove the federal government to actually start controlling this so that they could make sure that patients are getting stuff that's high in CBD. But anyway, we launched this survey to demonstrate to physicians and healthcare providers that there's a significant population of patients that are currently utilizing or have utilized it in the past and that they do want to talk about it. And so healthcare providers can't just like put their head in the sand and pretend like it's not an issue. Because if they don't talk to their patients about it, then patients won't, you don't know, and then you might prescribe them something that's contraindicated. So you don't want to also give them a muscle relaxer if they're also using marijuana, because that can have depressive respiratory effects. Right? And then you've got a real problem with people who are compromised already. You don't want to double up on depressants because then they'll stop breathing, right? So that's a problem. But I used to get asked all the time, people are like, oh, so you're a marijuana user then? And I'm like, well, so first of all, this isn't about me. This is about our patients. But yeah, a lot of people research it that don't actually sample the product, as Ron was saying. This was just a survey. Other questions about this?
When do you use confidence interval in statistics?
Always.
I don't see. It's not here.
Right, so these are confidence intervals right here. This is a confidence about...
What's the difference between standard error bars and confidence
Okay,
interval?
so standard error bars, that's a really great question. Standard error only assesses the variability about your mean.
Okay.
Right? So standard deviation is the variance in your sample.
Mm-hmm.
Standard error is the variance about your mean estimate. Remember, if I did this sample over and over and over again, I wouldn't get the exact same mean value every time. I'd get a slightly different mean value. The standard error speaks just to the variance around the mean. The confidence interval speaks directly to how sure we are that the real mean is in that max to min.
Okay.
So when I say my mean has plus or minus this standard error, that's specific to your mean in this study.
Mm-hmm.
If I talk about the confidence interval, then I'm saying I am 95% confident that the real mean value is in this window.
But your p-value is pretty high for some of the, if you scroll on figure 1.
Mm-hmm.
So can you still be like 95% sure it's within here? So like the
Yep.
8 versus 0, p-value is like 0.63.
It's a large p-value, but I'm still 95% sure that the true odds ratio is in here somewhere. But because it's not different than 1, I don't actually care what it is. It's just not different from 1. Right, so there's lots of moving parts here. So if you think about this, like the 3 versus 0, our data estimated approximately an odds ratio of 2. That means we're saying that the people who have a disability level of 3 are 2 times more likely to be current marijuana users than those with normal levels, so no disability. I'm 95% confident that that odds is somewhere between about 1.25 and 2.5. So it could be as low as 1.2 times more likely to be current users of marijuana, and it could be as high as 2.5 times more likely. We observed it to be this, but we're 95% sure it's within this value. When you have a significant p-value, your confidence interval will not include 1. When you have a non-significant p-value, I love the aha moment. And when you have a non-significant p-value, your confidence interval will include 1 for odds ratios.
I was like, then why is the p-value there? Because if you're already confident. Oh, okay.
Yep.
That doesn't make so much
The
sense.
p-value here tells us that this odds ratio is no different than 1. The confidence interval includes 1.
Okay. Yay.
Would you please, real briefly, you just defined standard error, standard deviation, and confidence interval. That really was very helpful, but I didn't write it down fast
Okay.
enough.
Standard deviation
Right.
defines the variability in your sample.
Okay. That makes sense.
Standard error speaks to the variability of your mean estimate. So what's the variance on my mean? And then the confidence bound tells me how sure I am that the real population mean is in that range. So standard deviation is about your data, how variable your data is. Standard error is about your mean value, how much variability is there in the mean value. And the confidence interval tells me how sure I am about the true population mean, not your sample mean.
Hold
on 1 second. Did you get that, Ron?
Yeah, which would be epsilon, is that right? The population mean, or
That's your mu.
mu.
Yep.
Very good, thank you.
It's okay. Eleanor?
Yes. Since we use it all the time, then why didn't we use it during this course?
Use what all the
Like,
time?
The confidence interval. Why do we use calculated?
Because we don't have enough time in this class to get to inference.
Oh, wait, what is inference?
Inference is when you take your information from your sample
Mm-hmm.
and infer it to the population at large.
Okay.
So we have spent a lot of time estimating our data,
Mm-hmm.
right? Estimating what our population percentage is, what our sample percentage is, what our sample mean is. We've talked about odds ratios. We've talked about prediction from correlation.
Mm-hmm.
The next step, and you've actually been doing inference with your p-values. So
Yeah.
I've concluded that there's a difference in the mean systolic blood pressure in the population, right?
Okay.
We've been saying in the population or in this population a lot.
Mhm.
You're
Yes.
inferring that difference exists in the population based on the data you collected. The confidence interval gives some measure of how confident I am of what the real proportion or real mean is.
Okay.
That's inference. We just really don't have the time in this class in one semester to really delve into confidence intervals and inference. You've been doing it, we just haven't really called it that.
Okay. So what is the next class you were supposed to take after this class?
So 601 for the MPH is designed as its standalone course, right? That's your core requirement. This fall, BST 613 is available to people who have taken 601.
Okay.
But otherwise, you can take BST 625, which is the design and conduct of clinical trials, which isn't really a stats class. It is, but it isn't. And then you could take 611 and 612, which takes everything that you've learned this semester, stretches it over 2 semesters so you can go even deeper into the courses. So you guys basically have learned like swim school. If you use the swimming analogy, like this is swim school. You guys have gotten in the water, you're comfortable with the water, you can hold your breath, you can blow some bubbles, you can swim some laps. The next level would be like if you joined a swim team. That's 611, 612. Right? And so you would learn more about it. You'd learn how to improve your strokes. You'd learn how to hold your breath longer. You'd learn how to dive into the water. And then our graduate students in biostatistics, that's like NCAA or like Olympic level swimming, where they learn the theory behind it and they have to do all the mathematical calculus stuff. So if you want more, if you really like statistics and you have the time, I would recommend the 611, 612 sequence. You've already got a good head start on that. If you want to learn more about design of studies, that's BST 625. That's the design and conduct of clinical trials. And if you want to learn more about other types of analyses, so if you want to learn more about logistic regression, if you want to learn more about linear regression, if you want to learn more about repeated measures, so that's measures over time, and if you want to learn more about non-parametric, and if you want to learn more about time to event, so we haven't even brushed the surface on survival analysis, that's BST 613, and that's this fall, and that's with me, and that's online.
Okay.
Or, if you really, really like it, you can just come get your master's or PhD with us. Or your DRPH.
But, yeah.
Candace's face was like, oh, good God, no.
But apparently, if you don't have a math degree, you can't get it. Like, I look at the requirements.
Yeah, well, so you don't have to have a math degree. Most of our students coming into biostatistics do not have math degrees. They have math background. So you have to have had linear algebra. And you have to have had Calc 2 for our MSPH and DRPH, and you have to have had Calc 3 for our masters and PhDs. We have had students that have come through the MPH program in EPI that have liked the biostat classes so much that they went back and got their prerequisites and then enrolled in their master's program, and one of those students just finished her PhD.
What is DRPH?
DRPH is a doctorate in public health.
Oh, yeah, right.
Right.
Okay.
So it's so a PhD is considered what's called an academic degree. So it's theory-based, where to finish your dissertation, and this is true across the board of any PhD, to do your dissertation, you have to develop new theory in whatever you're doing. For biostats, that means that you actually literally have to invent new statistical methods. It's not fun. I did it. And the DRPH is what's called a professional degree. And so for a DRPH, you have to actually apply the knowledge in a way that it has not been previously applied. So you don't have to develop new methodologies, but you do have to apply existing methodologies in areas that have not previously used them. So it's a practice degree. But we have a DRPH in biostatistics. It's their concentration in biostatistics. And so they take a lot, they don't have to take the calculus-based theory courses, but they have to take the calculus and linear algebra-based applied classes. And then they take a number of 700 level biostat applied courses.
Okay.
Oh, excuse me. Other questions?
I'm leaving.
Okay, bye, Ron.
Take care. Thanks.
It's good to see you.
Thanks for the memories.
Yes,
I don't have
absolutely.
anything else.
All right.
All right, bye-bye.
Bye. Thank you.
Bye. Sure.
Okay, you want to say bye?
Bye. Become a programmer.
You wanted to say bye.
I just want to talk to you guys.
Aww.
You have to go away.
I know. Because I have other work to do.
Right.
Yeah.
See you later.
Bye.
I
Thanks,
hope you
Candace.
guys
Eleanor or Meg, any other questions?
Yes. If you want to get a DRPH in biostatistics, are the classes that we're taking now count?
Nope.
Or like, okay, no.
No. So
Wow.
what they would count for now is that if you finish your MPH or large parts of it, that alleviates you having to take those courses in the DRPH.
Oh, the core classes.
Yeah, you don't have to take the core
Okay.
classes. So if you come in without an MPH, you have to take 5 core courses. If you come in with an MPH, those are waived.
Do you remember how many credit hours, or should I should just go?
Yeah, it's 60, I think, 62 or something for our DRPH. And so it's sort of split, about half of them are biostats. You take the core biostat courses, and so you'll be in the core applied courses. You'd be in the core applied courses with our MS and PhD students. It's the first 3 semesters, but you have a different theory course. You don't take the full theory. They have 3 semesters of theory. You have 1 in the DRPH.
Okay.
And then you have a sequence of 5 classes that you select with you and your advisor that are of your interest. So we currently have students that are doing maternal and child health and diabetes. So she took 2 maternal and child health classes, and then she took 3 biostat classes for longitudinal, and or 2 biostat classes and 1 epi class. We have another student, 2 students that are interested in HIV, and so they'll take the epi courses for infectious diseases. One of them took a biology course about like just literally the core infectious. It was a cell biology class, I think, and 2 biostat classes. So you get to build your own specialty track for what you're specifically interested in. And that's another place where the biostat DRPH differs from the PhD. The PhD is much more general. The DRPH, you will have selected an area of interest. Whether it's cardiovascular or HIV or injury or cancer, and we'll try to build those 5 classes around that area. So you get content knowledge plus biostat knowledge. And then much like the MPH where you have an internship, the DRPH has a practicum. So you actually spend 3 to 6 months working with a public health organization to answer a question that they have with data.
Okay.
So it's cool. It's almost like doing a mini master's degree in your DRPH. And then you do your dissertation. So.
Okay.
But if I'm happy to talk to you about it anytime. If you're really interested in this, then I would recommend maybe picking up 613 this fall. Or
I want to take it, but I wonder whether it can be an elective class. It can be counted as an elective class for my track, which is epidemiology.
I think it is an elective for epi, but I don't. You'd have to talk to your program director.
Yeah, I will talk to them. But I'm really interested in that class. Thank you.
Good, absolutely.
Thank you for making this class so fun.
Oh, I'm glad that you liked it. We try. I know a lot of people are scared of it, but it can be really interesting if you let it.
Okay.
So.
And I was wondering, what is your requirement for the TA if I want to come back as your TA? Is that possible?
For the 601 class, probably not. But
Okay.
for the undergrad PUH 250 and for the new quantitative methods course with Dr. Austin, 601 would likely be sufficient for you to be a TA.
Okay,
So,
thank you.
Absolutely, absolutely. Have a good afternoon. Good luck.
Have a good afternoon.
All right.